calm in presentation that we see. The challenge would be in the management and how a pediatrician would like to approach the case. Also, how to identify early problems and how to treat them. So that would be the crux of the discussion today. Happy to be learning from you all and happy to be participating in this. Thank you.
Dr. Naveen, you can start your presentation. Dr. Naveen, unmute.
Good evening, all. First of all, I'm extremely grateful for this huge learning opportunity given to me. With a huge thanks to everyone, I'll start my presentation about this case of Anasarca with fever and abdominal pain. So this is a 4.5-year-old girl child who was brought by her mother, who was from urban limits of Coimbatore with complaints of abdominal pain for the past 2 days and fever for the past 1 day. The abdominal pain was acute in onset, was progressive in nature, was present for the past 2 days. It was a dull, aching type of pain. It was diffuse in nature. There was no aggravating or relieving factors. This pain was associated with an abdominal distension, which was present over the past 7 days and was insidious in onset, involving the whole abdomen, and it was not specified to any single part of the abdomen. And there was a history of loose stools, which was 3 episodes in the last 24 hours, which was small volume stools, and there was no blood or mucus in the stools. There was no history of associated vomiting. There was a history of skin discoloration in the form of redness, that is erythema of this over the abdomen, predominantly around the umbilicus. There was a history of pain on touching the erythematous surface. There was no history of discharge from the discolored area. This abdominal pain and distension was associated with a high-grade fever, which was intermittent in nature, relieved by giving antipyretics. And just to recur, after 4 to 5 hours, was present for the past 1 day. There was a history of facial puffiness, which started 7 days back from the face, then went on to involve both upper and lower limbs and to present as a abdominal distension. There was a history of decreased urine output for the past 7 days. It was progressive, and the child was passing once or twice small quantity volume over the past 24 to 48 hours. There was no associated history of hematuria. There was no history of cry or increased frequency of micturition. There was no urgency of urination, and the urine wasn't foul smelling. There was no history of associated cough, rhinorrhea, or breathing difficulty. There was no exertional dyspnea or orthopnea. The child wasn't drowsy or didn't have any visual disturbance over this period of illness. There was no altered sensorium or convulsions or any deficits. There was no rash or arthritis. There was no yellowish discoloration of skin or sclera. There was no blood and vomiting hematemesis. There was no melena or hematochezia. There was no history of deformities in the long bones. There was no history of any loss of appetite, loss of weight, or hair changes before the period of illness. And there was a fair loss of intake over the past 2 days because of fever and abdominal pain. There was no history of intake of non-steroidal anti-inflammatory drugs or any drugs other than paracetamol for this illness during this episode. There was no history of bleeding of gums or generalized body ache or specifically bone pain.
Ma'am, do you want to ask anything after this present illness, madam?
History of drugs he was telling, NSAID. Any other drugs child received in the past for this illness?
For this illness, the child was getting only paracetamol for the fever, ma'am. That was given by the mother. She didn't take the baby to any other hospital before presenting to us. So the child was getting paracetamol, normal, usual dose.
Telling this is presenting this as a generalized edema from head to foot, you are telling.
Yes, ma'am.
How you ruled out cardiac or renal in this case? Cardiac or renal? From the history.
Yes, ma'am. Yes, ma'am. Child was able to walk around and was playful before these 2 days, ma'am. After this also, child was able to walk around, can do the routine chores, but wasn't feeling breathless, wasn't feeling easily fatigable, ma'am. And the child did not complain about any increase in breathing difficulty or inability to lie down.
Regarding starting of the edema, cardiac and renal, how will you question it? It's a basic question.
Yes, ma'am. The edema started preferentially over the face. Mother noticed the edema to be particularly on the face, especially around the eyes. It was more of a periorbital edema, which was seen initially on early mornings when the baby wakes up. And then it insidiously progressed to involve the upper limbs and the lower limbs simultaneously without any dyspnea or orthopnea. And there was an associated decreased urine output also.
Whether history of jaundice is important?
Yes, ma'am. Because I was worried that if there was any jaundice and any associated liver disease is the cause of this jaundice, even though it is less likely, I wanted to rule out liver specific diseases.
Distension of abdomen you are presenting. So,
yes, ma'am.
Okay, madam. Any urinary output you have mentioned already.
Yes, ma'am. Yes,
urine output.
So just a question here, Dr. Naveen. So
Yes,
would you like to further explain the puffiness, facial puffiness with regards to the duration and the timing during the day? Whether any diurnal variation to the edema? Probably that was not brought out in your present illness. Do you think the edema was there throughout the day, or did it increase or decrease during particular point of the day?
It was minimal on waking up, ma'am. By the evening, it was more on dependent parts.
Mm-hmm. So you're saying that it was very little to start with, and where was the
yes,
edema
ma'am.
to start with?
Yes,
In
ma'am.
the morning?
Yes, ma'am. Yes, ma'am.
Naveen, what Dr. Suganya wants is, can you tell the progression of edema from the throughout the day and the night? So when was the maximum edema around the face noticed by the mother?
Yes, ma'am. There was not much of a variation with the diurnal parameters, ma'am. It started in the as a periorbital puffiness, and it was the same with and the day progresses, and at the end of 7 days, it came to this point. There was no history suggestive of it goes off while sleeping, or it goes. It was more towards the day. It started as periorbital puffiness. It was only progressive. It never regressed at any part of the day or night.
And the child was mobile, or the child was confined to the bed during this period of illness?
Yes, for the past 2 days of the abdominal pain, on the first day, the child was able to move around. But on the day of presentation, just 6 to 5 hours before the day of the child was not able because of the pain in the abdomen. She preferred lying on the bed.
Okay. Okay.
Move on, Naveen.
Yes, ma'am. Going on to past history, there was a history of an episode of edema and puffiness of face 1 year and 2 months back. And that episode was treated with oral medications as daily regimen for 6 weeks and an alternate day regimen for 6 weeks, and it was stopped. And the mother is so clear that it was illness associated with kidney, and it was known to her that it is due to leakage of excessive proteins in the urines. And mother is very well aware that the drugs the child is getting are steroid drugs. The child was asymptomatic for 1 month from the stopping of the steroids, but there was a history of a second episode of edema and puffiness of face after exactly 1 month after stopping the steroids. And again, the child was started on daily dose, for which the child responded very well and swiftly and was switched to alternate day steroids in a period of 10 days. While on alternate day steroids, the child again developed a similar episode of edema and puffiness of face. for which this time the daily dose of steroids were continued for 30 days. And again, there was a swift symptomatic response in edema, and there was symptomatic resolution, and was switched to alternate day steroids. But there was a fourth episode again on tapering to alternate day regimen within 2 weeks of tapering. And the child was again started on the same thing happened again. So what happened was, this fourth episode alternate day regimen, while the child is on that regimen, she lost follow up and never turned back to us. And from the history of mother, it is evident that the child was taking the drug for 6 months as an alternate day therapy. Even though the mother says it is an alternate day therapy, I'm skeptical that she didn't give it for an exact alternate day therapy. It seems more like the child was getting the medicine some 10 to 14 days in a month, not on an exactly alternate day basis. It was in a bizarre manner, that is 1, 2 days, 3 days continuously, and then she forgets, and it was not given for 2 days, and then 2, 3 tablets for alternate days. So on an average, the child was getting around 14 to 16 tablets per month. While on this kind of medication therapy, there was a fifth episode of facial puffiness and edema all over the body. And the child presented to a hospital nearby their house, for which the child was started on a daily dose steroids for 15 days. And then she didn't report to that hospital also. And that treatment was discontinued abruptly when the child was okay.
Naveen, would you go back to your slide? Because now there are so much of information that's been given on the previous slide.
Yes, ma'am.
With the permission of Dr. Uma and Suganya, there's a lot of information in this slide which he has told in the past history. What would you infer from this? You put a lot of information. Can you just say your inferences from this slide? It started in 2019, and now we are sitting at the 2021. So over these 2 years, what would you infer from so much that's happened to this child?
Yes, ma'am. This illness has started for this child at an age of around 2.5 years, ma'am, and it was found to be a renal illness with an increased protein leak in the urine, and was being treated with steroids.
What is the educational status of this mother? Because you're categorically telling she knows it is leakage of protein, she is giving a steroid, and a lot of things you're mentioning. What is the educational status of this mom?
She has completed an undergraduate degree level, ma'am, in arts. So she is able to tell what is going on. Even she is able to interpret the reports from the lab value. She is somewhat shrewd enough to understand things, ma'am. And from this history, and it is very clear that it is a renal illness due to leak of proteins, and the drug which has been given was steroids, and the regimen is also clear here. But what happens here is, whenever the drug is withdrawn, or whenever the dose is being tapered, the symptom is recurring here. So while restarting the drug, and the symptoms immediately and swiftly respond to the drugs. So seems more like a nephrotic syndrome and sensitive to steroids only. But being dependent here, because whenever we try to taper the dose or stop, it just immediately recurs. But what is worrying here is, without any medical intervention for past 6 months, the child has been getting so much of steroids on a bizarre manner. So, so we have to look upon what is the steroid has done to the child. That is more worrying here in this part.
Dr. Naveen, here,
Yes, ma'am.
because you think that this child has a renal illness and
Yes,
most probably a nephrotic syndrome, because you say so.
Yes,
What is about do you think the child has been treated adequately, at least in the initial 1 or 2 episodes? So what is your inference? What is the treatment and the compliance to the treatment? What do you infer from this, from the history that you have given us?
Yes, ma'am. Initial 2 to 3 episodes, the child has been adequately treated, ma'am. There was, even though there was recurrences of this illness, she promptly presented to the hospital and was treated adequately. And again, there was adequate dose was given, and the child also swiftly responded. Yes, ma'am. The treatment that has been given earlier was adequate, ma'am, I think.
So can you define the term adequate that you were saying? How did you get that from the history?
Yes, ma'am. Whenever they start the steroids, within 7 to 10 days, the child started improving in terms of edema, and urine output of the child improved, and the child was doing well within 7 to 10 days of the start. So I think, so this is a swiftly responding kind of illness to steroids, ma'am.
So when you
So
elicit the duration of treatment or the dose of the therapy or any other test that was done to confirm whether this child has responded to treatment, was the mother able to give that information, or you don't have that information?
I try to make out the dose also, ma'am. But she can only remember that it was daily and alternate steroids. So she is not so aware that how much of the tablet strength exists and how much we are giving, how much it is being tapered. She is not able to give that information to me.
They've assessed the treatment response with the decrease in the swelling.
Yes, ma'am. Yes, ma'am. A doctor is giving a tablet, and it is when it is given on a daily basis, the symptoms resolve immediately, and they are decreasing the dose step by step. That much she is able to tell me.
So can we move on to the next?
There was no history suggestive of renal biopsy during these episodes of illnesses. There was no history of treatment or intake of any other drugs other than the steroids. The mother is so clear that only this particular tablet is being given, and no other medications was given on a longer duration, more than 3 to 5 days. There was no history of hematuria or lethargy, decreased activities, vision disturbances, altered sensorium, or seizures in the past 1.5 years during which the child has started this illness. There was no history suggestive of recurrent urinary tract infections, no cultures done, or no proven urinary tract infections in this past 1.5 years of illness. Moving on to antenatal history, the age of consumption, the age of mother at the time of consumption was 27 years. It was second gravida, that was a booked and immunized pregnancy. There was no history of first trimester illnesses like fever with rash. There was no history of irradiation or any other drug intake other than iron, folic acid, and calcium. Antenatal scans done, 4 scans were done. Anomaly scan was also done. It was normal. There was no oligohydramnios or no information suggestive of large placenta. The baby was delivered by a full-term normal vaginal delivery. The baby cried at birth. The weight was 3 kilograms, and there was no necessary for any NICU admission for the baby or treatment. The baby was discharged on day 3 of delivery, day 3 of life. Developmental history, she is able to come downstairs with 1 foot at a time, can copy a square. She tells stories and able to name parts of face. She goes to toilet alone, and she is developmentally normal for her age. Immunization, she is being immunized as per national immunization schedule at Urban Health Center near her house. The last vaccination done was at 3 years of age. That was a DPT, which was given under the whole coverage of DPT, which was done by the government of Tamil Nadu. The pneumococcal and the influenza vaccines were not given. She is getting only the vaccines that is being provided at the Urban Health Center. Nutrition wise, she has an intake of 1000 calories on expected 1400 kilocalories and 15 grams of protein on an expected 25 grams of proteins. There was a deficit of 400 kilocalories and 10 grams of proteins. Mother is aware that it was advised to give the baby a salt restricted diet. She is aware that she was giving a salt restricted diet during the initial episodes of the illness, but at present during this episode or in the last 2 episodes, she was not strictly adhering to the salt restricted diet. Other than that, there was no history suggestive of a nutritional deprivation to the child. She is getting enough amount of fruits, green vegetables, eggs, and dairy products. Family history, this is a second born baby of non-consanguineous parents. The other sibling is 7 years old. It is a boy child. There is no history of similar illness in the sibling, or no similar illness in the parents during their childhood or at present. There was no history of running renal disease in the family, in the first and second degree relatives. And there was no history of dialysis done to any member of the family. The father runs a small scale business, and the mother is a housewife. They belong to a lower middle class family as per modified Kupaswamy scale. There was no history of contact with an open case of tuberculosis, or no history of allergy to any kind of drugs or food items.
Naveen, can you sum up your history before you go to the examination? What are the pertinent things in history which you think is important for this child?
Yes, ma'am. This is a 4-year child with complaints of abdominal pain, fever, abdominal distension, decreased urine output, with similar multiple episodes of facial puffiness and illness, swiftly responding to drugs and recurring on tapering the same drug is there, ma'am, without any features suggestive of CNS illnesses like altered sensorium or any hematuria or any other systemic involvement indicating orthopnea or dyspnea or jaundice.
One question.
Predominantly, yes, ma'am.
One question.
Yes,
Recurrent problem with a similar complaint. How hematuria is important in this? Repeatedly, child is coming to you with the
Yes,
same
ma'am.
right?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Treatment.
Yes,
You have brought out the history of hematuria, how it is
yes, ma'am.
in this case.
Yeah, yes, ma'am. In this case, whenever the steroid is being given, the child is swiftly responding to it. Even though it seems more sensitive to steroids, we are not able to taper and stop the steroids. So even though all the history and previous episodes and steroids are in pointing us towards to probable nephrotic syndrome of a steroid sensitive type, still the relapses, more frequent relapses, and the dependency on steroids makes us think that it can be more than a minimal change disease.
That is very important.
Yes, ma'am.
Do you think the sensitivity to steroid helps you make the diagnosis as well? The response to the steroid. So you said you are thinking
yes,
other than a minimal change disease,
yes,
right? In the history.
Yes,
so
ma'am. Yes, ma'am.
In the history you brought out, and you were repeatedly also commenting that the child has responded to steroids. So do you think that has any bearing on what sort of nephrotic syndrome you're dealing with?
Yes, ma'am. Even though it is swiftly responding, even though it is swiftly responding and pointing us more towards the minimal change disease, if it is going to be other than minimal change disease, it is not going to be this responsive to the steroids. Still, in the back of the mind, I think 20 to 30% chances are there, even for it to be a non-minimal change disease, even though it is steroid responsive. I'm thinking more of a minimal change, but still I more worried that why it is relapsing again and again.
Diagnosis as well, because of the recurrent nature of the disease.
Yes, ma'am. Yes.
So although that is not true, steroid sensitiveness is almost equivalent to minimal change disease. Probably we can discuss it more when we are discussing about the cases. A couple of things in your history, and also you were commenting that this child had prolonged duration of alternate day steroids. So do you want to elicit anything regarding complications of drug therapy or anything in your in your history? So this child has got prolonged therapy without any supervision of therapy because the patient has lost to follow-up. So 6 months is quite a long time to be on a particular drug, in this case. So do you think you should be eliciting more history regarding that?
Yes, ma'am. Yes, ma'am. I asked a few history about that. There was no history of an enormous increase in her appetite or food intake. There was no history of a sudden weight gain in her, and there was no vision disturbances or CNS manifestations like confusions and seizures or any kind of focal deficits, ma'am. And there was no marks suddenly visible or was appearing over the past 6 months on her skin. There was no significant skin changes, and she has been gaining weight in a gradual manner only. There was no sudden or adequate weight gain or appearance in her face.
So you might add history of increased micturition or increased thirst, because some of these children do develop high blood sugars and develop polyuria and polydipsia. So you might want to add that to your history.
Ah.
And with regards to the diet history that you were mentioning,
Yes, ma'am.
so do you think the child, you said, was not on any specific salt restricted diet? Was there any fluid restriction also which was advised, or the child was drinking freely?
Yes, ma'am. It was advised. Mother knows that the child needs a salt-restricted diet, but it was taken very seriously during the initial episodes and was strictly adhered to, ma'am. But with the subsequent episodes, she wasn't so particular, or she wasn't so meticulous about the salt-restricted diet, and I think that was not followed, ma'am. From the history, I don't feel that she had followed the strict salt restricted diet even during the illnesses immediately after discharge from the hospital in the subsequent episodes, even when she is aware of it, because she knows that with giving the tablets, I personally feel, because while starting the treatment, she is going to swiftly respond, and she is aware that once she is asymptomatic, no edema, and we taper to alternative drugs and the urine output improves, she is aware that she can go back to the normal salt diet.
All right.
So that doesn't worry her so much.
Okay. Dr. Naveen, and in summary, do you want to mention, do you think this child has any other illness associated with the renal illness? So do you think, because of the presentation that the child has got fever, the child has got abdominal pain, so do you
Yes,
think
ma'am.
it's common in nephrotic syndrome, it's isolated nephrotic syndrome, or you think the child has some other problem associated with nephrotic syndrome here?
Yes, ma'am. There is problem associated. There is a fever and there is an abdominal pain. There is some erythema over her abdominal wall, and she is constantly complaining, and she is not even she doesn't even want to move from because of this abdominal pain. I think there is some intra-abdominal pathology going on in the form of infection associated with this episode of nephrotic syndrome.
Nephrotic, yeah.
About the relapses, 5 times child has brought a
Yes,
similar
ma'am.
complaint.
Yes, ma'am.
Whether each and every time associated with some respiratory or other infection.
Yes, ma'am. First episode was associated with respiratory infection, ma'am. But there was history. When I tried to elicit this history, I could make out that as there are too many episodes, she can only remember few episodes had happened without a triggering factor, and which episode happened after a triggered factor, and which episode happened without a trigger factor. I couldn't be able to make out from the history. First episode was associated with a respiratory infection, and this one with a gastrointestinal infection. There was triggers, but I couldn't relate which episode was associated with illness and which is not. So that's why I didn't bring it in that history.
In any nephrotic, 1 minute. In any nephrotic syndrome case, family
Yes,
is
ma'am.
important. You have elicited that.
Yes,
In
ma'am.
this case,
Yes, ma'am.
how it is important. Family history, not significant, there is no involvement you are telling. Which type
Yes,
of
ma'am.
nephrotic syndrome you can think? Suppose family history is important, present of similar. Which type? You can think and go about
Yes, ma'am.
what investigation.
But congenital nephrotic syndrome presents even before 3 months, ma'am. So in this case, we cannot think about it.
Age, 2.5 years, 3 years only child has developed.
Yes, ma'am. 2.5 years only this child. Probably this can be hereditary nephritis with nephrotic syndrome. Or it can be a focal segmental glomerulosclerosis.
Segmental. In
Yes,
that angle, you have to think at this
Yes,
level.
Yes, ma'am.
Family history is important. Okay, ma'am. Dr. Suganya.
Can we move on, Dr. Suganya? Any questions?
Just that one, you had mentioned the history of dialysis is not there in the family. Why did you elicit that particular history?
Ma'am, I wanted to make sure even though there are no illnesses of facial puffiness and abdominal distension in the family, I wanted to know if there are any end-stage renal diseases running in the family. So that's why I elicited. So without knowing it is a nephrotic syndrome or any other renal illness, they could have known that there was dialysis. So I thought that would help my history to reach out to a renal disease running in family.
All right. Okay. So I
Can
think we can
proceed.
move on.
Move on.
Move on,
Yes.
Naveen.
Yes, ma'am. Going on to examination of the child, general examination, the child looked alert. There was generalized edema involving face, limbs, abdomen, and both lower limbs. The edema was bilateral pitting pedal edema. The child was tachypneic. Even though she was tachypneic, she was comfortable in supine posture with a minimal head and elevation. There was no pallor, icterus, cyanosis, clubbing, or significant lymph node enlargement. So this is the child. She was able to comfortably lie down supine, and there was full-blown facial puffiness, predominantly over the periorbital area, it involving all in the face. So vitals, heart rate was 140 per minute. There was tachycardia. The rate was regular. The rate was tachycardic, regular in rhythm. There was normal volume, and all peripheral pulses were felt. There was no radioradial or radiofemoral delay. Blood pressure was 100 by 60. It was between 50 to 90th centile for her age, sex, and height. Respiratory rate was 32 per minute. Was a bit tachypneic, and but she was able to maintain saturation of 100% in room air without any oxygen supplementation. She was febrile with a temperature of 99.9 degree Fahrenheit. Assessment of growth wise, she was 19 kilograms. She fell between 50 to 97 centile, and height was 102 centimeters, 3 to 50th centile. Midterm circumference was 14 centimeters, and head circumference was 49 centimeters, which was between 3 to 50th centile as per WHO chart. Head to toe examination, her head size and shape were normal. There was no hair changes. Hair looked normal. There was no facial dysmorphism or no Cushingoid features which I was expecting and was worried about. There was facial edema. Anasarca was present. Eyes were normal. No cataract was seen. There was no icterus. Oral cavity was normal. No ulcers or oral thrush. The jugular venous pulse was not seen. BCG scar also appeared normal. There was no induration or ulceration of the scar. The chest wall appeared normal. Hand and leg were edematous, and the skin over the abdomen was erythematous around the umbilicus predominantly. Other than that erythema of the skin over the abdomen, there was no other evidence of erythema or induration anywhere else in the body. There was no neurocutaneous markers, no petechiae, purpura, or ecchymotic patches over the body. Her bones and joints were normal. No deformities were found. There was sacral edema and vulval edema was present. There was no induration or ulceration over the vulva. Moving on to systemic examination. Examination of abdomen. On inspection, the abdomen looks distended uniformly. The flanks were full. Umbilicus was flushed with the surface. All quadrants of the abdomen moved equally with the respiration. There was erythema of skin over the abdomen, and predominantly it was peri-umbilical. There was no discharging sinuses over the skin erythema. No visible mass or dilated veins or pulsation seen over the abdomen. Hernial orifices were free. So this was the abdomen of the child. This photograph was taken immediately after the fluid tap. You can see a dynoplast there is taken, and it is morely painted with betadine just before procedure. And there is erythema just above the umbilicus. On palpation, the abdomen was warm and tense. There was diffuse tenderness all over the abdomen. There was guarding and rigidity. And liver and spleen were not palpable, and no other mass was palpable over the abdomen. On percussion, there was shifting dullness, but there wasn't any fluid thrill. On auscultation, bowel sounds were normal. No bruit or venous hum was heard. There was no friction rub of liver. The abdominal girth was 59 centimeters, grossly distended. And genitalia showed a vulval edema, as already mentioned. There was no induration or ulceration. Perineum and perianal area looked normal. There was no ulcerations or excoriations. Going to cardiovascular system, the shape of chest wall was normal. Chest wall was symmetrical, no precordial bulge or engorged veins. Trachea appeared to be in the midline, and the apex beat was not seen. There was no visible pulsations over the precardium. Jugular venous pulse was not seen. Neck veins are also not engorged. And trachea was confirmed to be in the midline. Apex beat was felt at 4th to 5th intercostal space in the mid-clavicular line. On auscultation, the heart sounds were normal. There was no gallop or murmurs. Respiratory system examination. It was an abdominothoracic type of respiration. Child was tachypneic, but there wasn't any increase in the work of her breathing. And chest wall and back were normal. Chest expansion and symmetry were normal, as already mentioned. And there was a stony, dull percussion note over her infraaxillary and infrascapular regions. But a resonant note of percussion was heard on other areas other than axillary and scapular regions. And there was no breath sounds heard over her infraaxillary and infrascapular regions on both sides. Normal vesicular breath sounds are heard in the rest of the areas. And central nervous system, her higher mental functions were normal. She was conscious. She was able to interact, recognize us, was able to talk to us, interacting well. And there was no cranial nerve abnormalities found. Her motor and sensory system were normal. There was no cerebellar signs. Her spine and cranium was normal. So my professional diagnosis in this case will be a probable nephrotic syndrome, which is frequently relapsing one, sensitive to steroids, but dependent to steroids, with Anasarca and spontaneous bacterial peritonitis this time.
A couple of things, Dr. Naveen.
Yes, ma'am.
In the general examination,
Yes, ma'am.
Is there any specific findings in the nails that you would like to look at for a child with renal edema?
Yes, ma'am. There will be dystrophy of nails, ma'am. I noticed there wasn't any dystrophy of the nails.
Did you mention it?
Yes, ma'am. I thought there wasn't any other congenital anomalies associated with this child. So just mentioning the nail alone, that's why I didn't bring it out in the history.
Okay. So some of these children, what is Muehrk lines? Have you heard of
Sorry.
it? So there can be some transverse lines in your nails which are whitish because of the recurrent hypoalbuminic states. So that is something that one can look for in a child with nephrotic syndrome or a renal cause of edema with low protein states.
Yes, ma'am.
So it's not very specific to nephrotic syndrome. Probably you can mention that.
Yes,
Can
ma'am.
you explain Cushingoid features? What all are the things that you looked for?
Yes, ma'am. I look for truncal obesity and moon face, moon like round face. But I look for a striae on her body, deposition of fat on her nape of neck. There wasn't any pigmentation, acanthosis over her nape of neck. In her eye, yes, ma'am. In her eyes, there wasn't any cataracts. It was clear, lens was clear. There was a good pupillary response. And there was no excessive hair over her body, and she wasn't short stature, ma'am. She is in a appropriate height for her age.
Was there any wrist widening? Was there any?
No, ma'am. No bony abnormalities, ma'am. No bony, no wrist widening, no varus or valgus deformities.
Why do you think that is important, Naveen? Widening of the wrist in this particular child. Why do you think that's important for us to see?
Yes, ma'am. I thought there is a renal illness, whether a renal osteodystrophy part can be present associated with this illness.
So more than osteodystrophy, anything else? You have written that nephrotic.
Steroid toxicity, ma'am. I also thought of that. There was a prolonged steroids, ma'am. So,
no, it is not toxicity. What deficiencies can come if you've been on steroids for so long and your diet is going to be restricted? So that you're going to look for rickets, okay? More than the osteodystrophy, it's a child nephrotic syndrome, okay?
yes, ma'am.
And the calcium per se can be less when you have hypoalbuminemia for a long time, okay?
Yes, ma'am. Yes, ma'am.
Right. So you have put a diagnosis of nephrotic syndrome. Dr. Suganya, would you want him to say why he thought nephrotic? It's very basic, but we thought we can start from basics itself.
Yeah. Can I just ask a couple of more questions in the?
Yes, please.
So you did not mention anything about a skin rash or any skin lesions. But let's see, let's take if the child is having a skin rash. So what are the conditions that you would think of, especially when you're thinking of a renal cause or even
Yes,
a
ma'am.
non-renal cause? So if the child has skin rash, so what are the things that you would try and rule out?
It can be an early onset lupus associated with skin rash and nephritis, ma'am. It can be associated with
So what is early onset?
Before the age of 8 years.
Okay, so
Not usual presentation in the adolescent age.
The rash.
It can be a henox-conlin purpura, which can present with the palpable purpura, arthritis, and nephritis.
Where would you find the rash predominantly?
On the dependent areas, ma'am, gluteal areas and the lower extremities and hand part.
So can henox-conlin purpura also present in this way, say without rash? This child has had recurrent
Yes,
episodes of edema, you've given steroids and the child has responded.
Yes, ma'am.
What
HSP can
does not have henox-conlin purpura?
yes, ma'am. This can present as a nephrotic syndrome. This HSP can present without a rash, ma'am. But in HSP, we will not be finding this much of a huge edema, and there will be associated. There may be associated hematuria also associated with it, and definitely there will be arthritis and intermittent abdominal pain will be there, ma'am. But there wasn't any abdominal pain or arthritis over the past 2 years of this illness.
So it doesn't fit into the classical presentation.
Yes, ma'am. Yes, ma'am.
All right. So what other conditions can come with a skin rash again? So this child had recurrent episodes, but if the first episode the child has presented with a skin rash, so what would you think of?
I would have thought of initially HSP, ma'am, and it can be associated with other systemic vasculitis syndromes.
Would you think of something more common than that, something associated with infections rather than an autoimmune condition? So what infection can cause presentation like this?
Post-streptococcal glomerulonephritis. During that time, any streptococcal fever, scarlet fever, there could have been fever associated with rash, followed by which the child could have had a. Other than post-streptococcal, gram-negative bacteria can also cause a similar pattern of illness, fever with rash and followed by renal illness.
So usually it is a healing rash, right? So you have
yes,
a time lag between the onset of renal manifestations and the skin.
Yes, ma'am. Yes,
so usually you don't see an active infection, but you see the rash which is healing off.
Yes, ma'am.
All right. So coming to why do you think this child has nephrotic syndrome? The first part of your diagnosis.
Yes, ma'am.
You have put the child has nephrotic syndrome. So why do you think the child points in your history and your examination which favors nephrotic syndrome, please?
Yes, ma'am. The edema is predominantly so very high, unlikely likely of a nephrotic syndrome, more involving the periorbital area and abdomen and then limbs. It was a pitting type of edema, and there was a decreased urine output, which was not associated with any history or findings suggestive of hematuria or any CNS manifestation due to increased blood pressures And this age group was also with given history and the age group, it fits more into the nephrotic syndrome than in the nephritic illness pattern.
So you have a 4-year-old child, or the disease onset was probably say 2 to 3 years. So you have
Yes,
a
ma'am.
3-year-old child
Yes,
who's
ma'am.
having edema, which you think is probably because of a renal cause. And
Yes,
that
ma'am.
renal cause you think because there is predominantly facial puffiness.
Yes,
And
ma'am.
most of these children have an increase in the facial puffiness when they wake up
Yes, ma'am.
because of the dependency, and it comes
Yes, ma'am.
down throughout the day. So there is
Yes,
a
ma'am.
renal edema, and the
Yes, ma'am.
child is of 3 years of age. And
Yes,
from
ma'am.
the history, we were not able to elicit any other cause for renal edema, like chronic kidney disease or any other vasculitis or any other autoimmune disorder.
Yes,
Yet,
ma'am.
remitting and a relapsing course.
Yes, ma'am.
Right? So these are the points in favor of a nephrotic syndrome. And overall, the mother was also given a history of treatment with steroids.
Yes, ma'am.
So qualify your other parts of the diagnosis. Frequently relapsing. Why do you say so?
There has been more than 6 relapses in this 1 year period, ma'am. From the last December to this December, there has been 6 episodes, ma'am. So I think it is a frequently relapsing when we have this term to use when it is equal to 4 or more in a year period. And it is again setting in to have 2 or more episodes in the last 6 months. The child has had 3 episodes in the last 6 months alone. So I think it is a frequently relapsing one.
So the definition of 2 or more relapses is usually in the initial 6 months of disease onset. So if you have a
Yes, ma'am.
diagnosis of nephrotic syndrome and within the first 6 months of it, you have 2 or more relapses, you can
Yes, ma'am.
label somebody as frequently relapsing.
Yes,
Okay.
ma'am.
So next one is steroid sensitive. So what do you mean by that?
Yes, ma'am. So whenever we start with the daily dose regimen, there is swift resolution of symptoms within a period of 1 to 2 weeks. It was never more than 2 weeks to achieve symptomatic relief. So I thought it was swiftly sensitive to steroids. It
When
just responded.
is
Yes,
not
ma'am.
sensitive to steroids.
I consider it unresponsive steroids when the steroids full dose 2 mg per kg was given for a period of 4 weeks and it not attained the remission. I'll consider it to be a resistant one.
I mean, what is the average time in which the children become, they go into, they become less symptomatic after starting steroids? For example, if you're going to start 2 milligram per kg, what's the average time you think it takes for them to get a little better?
Yes, ma'am. It will be around 4 to 7 days. They will be responding in 4 to 7 days or at least within 2 weeks.
50% are going to respond within the first 10 days, and then
Yes, ma'am.
80% of them will be responding by about 2 weeks of steroid.
Yes,
Okay. So what's the next part? You've said steroid dependent.
yes, ma'am.
How did you come to that conclusion? First
I
of all,
thought
you
it was.
can, no, first of all, you please tell me what you mean by steroid dependent, and then how
Yes,
did
ma'am.
you decide on this particular patient?
Yes, ma'am. Any steroid dependent nephrotic syndrome, I'll define it as inability to taper the steroids because of the relapse relapsing of the symptoms while tapering the steroids, or when the symptoms appear within 2 weeks of stopping the steroids, I will call it a steroid dependent case. But here what happened was only once we were able to stop the steroids, that was for a period of 30 days. But after that episode, every episode was associated with the relapse whenever we tried to taper the drug. That is, we couldn't even stop the drug and wait for a period of 2 weeks, while just starting to taper with into the end of first week or the beginning of the second week, the symptoms just recurred like before. So I thought it is totally dependent on the high dose steroids, and I wasn't able to taper the dose. So I thought it will be a steroid dependent type of nephrotic.
Okay.
Dr. Naveen, in one of the episodes, you said the duration of treatment was 30 days
Yes, ma'am.
to achieve remission. So that crosses 4 weeks. So why didn't you label the child as steroid resistant?
In
4
that,
weeks is 28 days, right?
yes, ma'am. To be
Label the child as steroid resistance. Can you label the child as steroid resistance or?
No, ma'am, for that 30 days, one episode treatment, I wouldn't label, because from the history, I was skeptical that it wasn't advised to give the steroids for 30 days. She was supposed to present earlier. As that presentation or a review was delayed, she was continuing that thing, ma'am. It wasn't actually prescribed. So I think that wasn't needed. So I didn't include in making the diagnosis of steroid resistance.
At that point of time, for 30 days, was it an everyday steroid, Naveen, or was it an alternate day steroid regimen which this child was getting?
First 2 weeks she received here, ma'am, but after discharge there was a confusion. So she was giving, I presume that is a confusion in her. She wasn't able to tell why it was continued for 30 days.
Okay.
So in the diagnosis you mentioned is Anasarca. So what does that mean?
So why have you specifically said Anasarca in your final diagnosis?
I thought there is in a huge manner, ma'am. It involves the face, the chest wall was swollen, abdominal wall was swollen, the hand and feet were edematous. It was a pitting type of field edema with no urine output. So I thought it is a very severe generalized edema, and it was important to include it in the diagnosis.
There was genital edema as well.
Yes, ma'am, it was present. Yes, ma'am.
Okay. And was there any other fluid accumulation anywhere else in the body?
Yes, ma'am. There was fluid accumulation in the form of pleural effusion, ma'am. It was bilateral. I was able to make it in the examination itself, ma'am.
That be part of your diagnosis?
Yes, ma'am. I think it wasn't per se respiratory system abnormality. I think it is because of this nephrotic syndrome induced hypoalbuminuria state and transudative effusion only.
How are you confidently saying it's a transudative the child has fever?
Yes, ma'am.
The child has been on steroids. So do you think
Yes, ma'am.
make a comment that it's transudative pleural effusion because of hypoalbuminemia?
Yes, at this stage, why I'm telling this is because this fever has been for 2 days, and there is a definitive focus of infection in the abdomen. There wasn't any associated respiratory system symptoms or cough or breathing difficulty or increased work of breathing. So I think rather than considering it as a primary respiratory system involvement, I will say it is associated with this hypoalbuminemic state only.
There's already one infection in the abdomen.
Yes, ma'am. Yes.
Infection in the chest as well.
That's why I said there was no clinical history or examination wise. There wasn't any clue to say that it is a respiratory system infection.
But I think when we have an immunocompromised child who's been on steroids for months together, we should
Yes,
think a little more and be a little cautious before we label it as there is no infection in the lung. Okay, you
yes,
yourself said it's been there on long-term steroids, so we have to be
yes,
a word of caution before you
yes,
categorically say it is a plain pleural effusion and nothing else.
Yes, ma'am. Even though I bring it as pleural effusion because of hypoalbuminemia, anyway, in the evaluation, I'm going to make sure that it is not infection associated.
You can probably avoid the term hypoalbuminemia or transudative in the diagnosis. You can just mention by confirming with your clinical findings, you have got a child with probable pleural effusion. Okay?
Yes, ma'am. Yes, ma'am.
Right. So spontaneous bacterial peritonitis. So how did you come to that conclusion?
There wasn't any triggering factors to develop an intra-abdominal infection for this child, and the child is on steroids, has been on steroids for a very long time, and suddenly presenting with tense abdomen, and there is a long accumulation of fluid in the abdomen, favoring it for infection in case of immunocompromised child like this.
Plus, the most important thing, your patient is having erythema in the abdominal wall. There is some tenderness.
Yes.
All that is a thing to say that there is a peritonitis in this particular patient. Okay?
Yes, ma'am. Yes.
This child also had loose stools in your history. So do you think
Yes, ma'am.
Bacterial peritonitis can be associated with loose stools?
It may be associated with loose stools, ma'am.
Generally, can children with nephrotic have loose stools, Naveen?
Ma'am?
Generally, in a child with nephrotic, can they have a watery stool? Hello?
Yes, ma'am. Yes, ma'am.
Can they have this? Of course, this child had say fever, some diarrhea. Okay, can a child with
Yes, ma'am.
nephrotic have a watery stool for any other reason?
Yes, ma'am. They can have.
Why?
There can be intestinal wall edema, ma'am. So there will be uh, uh, hindrance in the water absorption from the
Okay.
through that intestinal
Okay.
villi. So they can have a watery stool. Yes, ma'am.
Okay. So now, what do you want to do for this patient? You have a diagnosis, you have a child in front of you. So
Yes,
how
ma'am.
are you going to go about with this patient?
Yes, ma'am. In this case, I'll be starting with a complete blood count and the urine for biochemistry for to look for the total leukocyte count, whether it is neutrophilic in predominance, whether how the platelet counts, or whether this is the bacterial peritonitis or is in sepsis, and I'll be quantifying the amount of protein leak in this episodes and to see for any associated microscopic hematuria associated with this episode. And after that, the going out to the part of a spontaneous bacterial peritonitis, I would like to do a diagnostic peritoneal tap immediately to see for counts and cultures, and we'll be starting antibiotics after these procedures. And before starting going with the antibiotics, I'll be drawing cultures for blood and urine. And and I'll be doing an ultrasound abdomen to look for any look for the blood flow in the renal vein and arteries. And I'll do a chest X-ray to rule out a respiratory tract infection or this is a pleural effusion.
Dr. Sugar.
Yes, ma'am.
No, you're not audible, Dr. Suganya.
Okay. Can you hear me now?
Yeah, now it's okay. Yeah.
Okay. So you said complete blood count. So
Yes,
what are
ma'am.
the things that you expect and you look for in the complete blood count in this child?
So, in this child, I'll be expecting a neutrophilic leukocytosis with probably normal platelets.
And,
Why are you stressing on the platelets?
If
What
this
if there is a
was
thrombocytopenia?
I'll think of a full-blown sepsis, and I will be more aggressive in my treatment rather than considering it as just a bacterial peritonitis and nephrotic syndrome.
so although these are recurrent episodes and you think it's predominantly a primary nephrotic syndrome, so what if there are cytopenias in your complete blood count? Say there is anemia.
Yes, ma'am.
Or there is leukopenia, or there is
Yes, ma'am.
thrombocytopenia. So would you like to consider other diagnoses other than what you've made? If in the investigations you unveil cytopenias, what are the things
Yes,
that you
ma'am.
would like to think in this child?
I'll be thinking of malignancies in times of bicytopenia or tricytopenia in this setting, ma'am. So I'll have to do a
In a child with proteinuria,
ma'am.
what malignancies do you think a child with proteinuria can have?
Will develop.
Will develop? What malignancies are associated with this condition?
She might be having acute leukemias, ma'am, with secondary nephrotic syndromes or lymphomas. She also can have lymphomas.
Lymphomas like Hodgkin's lymphoma, they are more commonly associated with a presentation like nephrotic syndrome.
Yes, ma'am.
Any other relevance to cytopenias?
Mm.
So a child with nephrotic
Post-viral, yes, ma'am. Post-viral marrow suppression, infection associated secondary nephrotic syndromes, there can be nephrotic syndrome associated with marrow suppression.
infections can cause marrow suppression.
Yes, ma'am. Parvo B19 can cause marrow suppression plus nephrotic syndrome secondary.
Specifically, so it will specifically cause anemia, isn't it? So
Yes, ma'am.
parvovirus infection. So you can have a child with intense anemia, very low
Yes, ma'am.
hemoglobin because of reticulocytopenia.
Yes,
And
ma'am.
can you can suspect parvovirus infection.
Yes, ma'am.
Otherwise, cytopenias, do you think apart from infections, are there any other causes where you can find cytopenias?
Yes, ma'am.
Any other systemic conditions, Naveen, where you can have
Yes.
cytopenias?
So, immunodeficiency, HIV infection, there can be cytopenias associated with.
Any immunological
Yes, ma'am.
causes?
Immunological, anything immunological which can have a renal as well as cytopenia.
Vasculitis syndromes can have.
Most commonly, your systemic lupus erythematosus.
It's early.
Any
Yes,
other
yes, ma'am.
autoimmune condition can present with cytopenias and also cause proteinuria. A
Yes.
presentation like this.
Yes.
Would you want to do a complement level in this child, Naveen?
As this is so far very sensitive to steroids, ma'am, at this point, it wouldn't add any diagnostic value, I don't think. But for completion's sake, as it is so very related to steroids, I'll do a C3 to make sure it is normal. But at
So
this point of time, there are infections, it may be low, ma'am. So, but for completion's sake, I will anyway do a C3.
So, what do you expect in your urine analysis in this child?
In this child, I'll be expecting proteinuria of 3+ or more than 4+, and not a significant microscopic hematuria.
So what is this 3+ you're talking about? By 3+, what do you mean? How much milligrams of protein is likely to be excreted in the urine?
That would be more than 30 milligrams per 300 milligrams per deciliter of protein. 3+ can 3+ or 4+, meaning 300 to 1000 or even more than 1000 milligrams per deciliter of protein.
So what do you expect the protein creatinine ratio in this particular child?
I'm expecting a value more than 2 for this child. It will be even for this edema, it can even be more.
So in a child with nephrotic syndrome, how can, what are the methods by which you will quantify or the definition of proteinuria, nephrotic range proteinuria?
Yes, ma'am.
How do you define it?
So I'll define it as a proteinuria of 3.5 grams per day in a 24-hour urine quantification test, ma'am. Or I'll define a protein creatinine ratio of more than 2 for this 3-year-old child. I'll define it as a proteinuria. In a dipstick test, again, I'll define it as a nephrotic range proteinuria when it is more than or equal to 3+ in urine protein, ma'am.
Right. Can you also do a timed sample? As you mentioned, 24-hour collection might not be very
Yes,
easy.
ma'am. Yes, ma'am.
So
Yes,
there's
ma'am.
another definition which based on timed urine collections. So what is that? So what is the quantity of proteinuria in that? How do you define nephrotic proteinuria?
Yes, ma'am.
No, anything per hour. See, we cannot have 24 hours. So
Yes,
per hour,
yes, ma'am.
so many milligrams per hour.
Yes, yeah.
40 milligrams per meter square per hour, maybe a nephrotic range proteinuria.
So this is the definition. All right.
Yes, ma'am. Yes, ma'am.
So you mentioned there was no RBCs in the urine. So can
Yes,
RBCs be in the urine in this particular child? Is it expected or?
In this setting, I wouldn't expect the RBCs more than up to a level of microscopic hematuria, ma'am. I wouldn't be expecting in this setting.
So is microscopic hematuria seen in a child with minimal change nephrotic syndrome?
Yes, ma'am. Very rarely it can be seen. It is not that it will never be seen. It can be seen, ma'am.
In how much percentage of children you can have hematuria?
Maybe seen up to 10%, not more than that.
50% of children in a urine analysis with minimal change also, you can find microscopic hematuria. Having gross hematuria actually goes against a diagnosis of minimal changes, which you think this child probably has. All right. So this child has infection. So in the urine analysis, would you like to look at other things also? Do you look for any other type of cells in the urine?
Yes, ma'am. I'll be looking for leukocytes, WBCs in the urine to rule out any urinary tract infections associated with this episode.
All right. So this 3+ test that you said, what is the method of urine protein estimation that is? What is it called?
Dipstick, ma'am. This was done by urine dipstick.
Are there other methods of protein estimation in the urine?
Yes, ma'am. Bedside tests are there other than this dipstick test.
What are they?
acetic acid test. One is there, ma'am, heat coagulation test, and the other one is a sulfosalicylic acid test. That can be done at the bedside.
How do you quantify proteinuria based on those tests?
When we complete the test and look at the test tubes, now when we are able to see through that urine, the other side, if we can see, just for example, if we keep a book and see through the test tube, if we are able to see the letters, find letters in the book, that will be trace or 1+. Now, when it is slightly turbid, it can be 1+, 2+. When they are more turbid, it will be 3+. When we can't even able to see the other side, it will be 4+.
Okay. So what are the tests? So would you do any other tests to confirm nephrotic syndrome? So you have nephrotic range proteinuria, as you said, the dipstick is 3+, so 4+.
Yes, ma'am. I'll be doing blood triglyceride levels and serum albumin to confirm the diagnosis.
Only triglyceride level?
A full lipid profile, ma'am. Total cholesterol, triglycerides, LDL, and HDL.
So what do you expect in a child with nephrotic syndrome? How would the lipid profile look like?
I'll be expecting triglycerides more than 200 milligrams per deciliter, and the HDL may be low, ma'am. LDL may be high, but it does not necessarily be the change.
So all the lipid fractions other than your HDL, you would expect it to be higher in this child? No?
Yes, ma'am. Yes, ma'am.
Okay. And what are the tests that will help you make a diagnosis? Serum albumin?
Yes, ma'am. Serum albumin and protein estimation tests and lipid profiles, ma'am. With this, I'll be able to make a diagnosis of nephrotic.
Albumin to be in this child?
Will be definitely less than 2.5 milligrams per deciliter to say it is a nephrotic syndrome.
Okay, all right.
Okay, so now you have established nephrotic syndrome. Suppose you've seen this patient for the first time, Naveen. It's not like first time you have seen. What will be your protocol of managing this particular child? Forget this multiple episodes and all that. First time you're seeing this child, and you made a diagnosis of nephrotic syndrome. So what would be your line of management?
I'll be if this child presenting with a simple nephrotic syndrome or with Anasarca and spontaneous bacterial peritonitis?
No, nothing. This child has come first time with a nephrotic syndrome. You have diagnosed nephrotic syndrome. There's no infection at that point. So what would be your line of management? What's the protocol?
Yes, I'll be starting oral steroids, prednisolone, 2 milligrams per kg per day for 4 weeks, ma'am, to initially start with.
Hello.
Hello, ma'am.
Continue. What will be your?
Yes, ma'am. Yes, ma'am. I'll be starting for 2 milligrams per kg per day for the first initial 4 weeks, ma'am. And then I'll review after 4 weeks and change the regimen to 1.5 milligrams per kg per day on alternate day basis for another 4 weeks. And then I'll stop it and I will look for proteinuria in between.
Is there any alternative way of doing this?
Yes, ma'am. There are other regimens where this 2 milligrams per kg per day can be given for 6 weeks and 1.5 milligrams per kg per day for alternate day for another 6 weeks, a total duration of 12 weeks also.
So why this total duration of 12 weeks is used in the first episode? Why do you think that is? From
literature, it has been found that the duration of 12 weeks has been found to reduce the recurrences, reduce the relapses, and to increase the period of remission in a child with the first episode of nephrotic syndrome.
Okay. Suppose the child is coming with a relapse. You gave steroid, child got well, and then has been doing well for some time, and then came. They say there was a relapse after 6 weeks, after say 3 or 4 months. So how would you treat a relapse? What would you say is a relapse and how will you treat a relapse?
I'll consider it as a relapse when the urine dipstick is showing more than 3+ proteinuria for 3 consecutive days. I'll brand it as a relapse and then again restart with the 2 milligrams per kg per day daily, and I'll be doing the urine dipstick every day. And when it is negative or trace for 3 consecutive days, I'll consider it to be have remitted, and then I will switch it again to an alternative dose 1.5 0.5 milligrams per kg per day for alternative days. And I'll advise it to take it for 4 weeks, and then I'll be sending the child home.
So what about the diet you will advise when the child is coming with edema? Okay, you're not admitted, it's on an OP basis. What kind of a diet and intakes you will advise to a mother?
Yes, I'll be asking her and advising her to give a diet which is rich in proteins. I'll calculate in such a way that the protein intake of the baby per day will be around 1.5 to 2 grams per kg per day, and I will allow the calories for her age appropriate calories for her, and I will ask the mother to come down on the fat so that it doesn't exceed more than 30% of her food intake. I'll make a diet chart for this kind of calorie calculation, and I'll ask her to adhere to it as much as possible. And I'll ask her to restrict the salts for at least the edema fully settles and the urine output is satisfactorily improved, and I'll ask her to restrict the fluids until the urine output improves.
So what do you mean by this salt? You will restrict means you must have a quantitation of
Yes,
it cannot be a subjective measure. You have to be objective.
Yes,
so how will you tell the mother?
I'll be asking her to give 1.5 to 2 grams per day of salt, and it is available in pre-packed salt packets, ma'am. So I'll make sure that she has got the packs, and I'll advise her to use only the salt in that pack of 2 grams per day.
What about fluids? Fluids you are telling no rest.
Yes, ma'am. Yes, ma'am. I'll ask her. As I already know the weight of the child, I will ask the mother to measure the urine as and when she passes and write it down in a notebook. I'll ask her to maintain a diary or a notebook to make a note of whatever the baby is taking and everything. And whenever the baby passes urine, I'll ask her to measure it, and I'll ask the insensible water loss of 10 to 15 ml per kg to the weight. And I'll ask her if the baby is going to pass 200 ml of urine, I'll ask her to add another for this baby 180 ml. I'll ask her to restrict between 500 ml. As the urine output improves for this age group, I'll ask her to stop doing this.
Okay, suppose this child is, please go on, ma'am, please.
What are the early markers of improvement you will observe during the therapy? Early markers of
there will be increase in the urine output, ma'am. The oliguria will resolve, and there will be obvious. It will be obvious that the edema is subsiding slowly.
Weight is important.
There will be weight loss. Yes, ma'am. The baby will start losing weight as and when we start steroids in 7 to 2 hours.
Abdominal girth.
Yes, ma'am. That will come down, ma'am. But I wouldn't be asking the mother to do it at home. Probably, if in hospital setting, I'll be measuring the abdominal girth every day, also as a mark of progress.
Also, the edema, wherever edema is there, whether it's lessening or not. 3 points we observe during the.
Yes, ma'am. Yes, ma'am.
Now that this child is coming back to see you frequently, at what point of time, Naveen, will you think, okay, this is not behaving as the way it should behave? I should go for some other investigations if it is needed. So what will make you think, okay, I have to think of something more than a simple minimal change? So what are the clinical markers which will make you think, okay, I need something more?
Yes,
Madam, with your permission, Dr. Uma, there are 1 or 2 postgraduates also who have joined the link. Can they give some answers?
Yes.
Suganya, is that okay with you?
Yes.
Dr. Suganya, is that okay with you?
Yes, ma'am.
Okay, maybe this question Naveen can take. And any more, there is Sriniti and Arun also waiting. Maybe they can also join in to put a few words. Okay, Arun, you can answer this question. When will you decide, okay, I need to do something more? I need to think of something more. Naveen?
Ma'am?
Please answer that question, Naveen.
Ma'am, I will take this question, ma'am. Yes.
Yes.
Yes, ma'am. Yes, ma'am. As is so far as it is going like a minimal change disease, when this child develop gross hematuria or persisting microscopic hematuria, or if there is hypertension on any of the sitting during the visits, I'll be thinking that this child might need more evaluation for this.
Microscopic. About microscopy, you are telling what
Yes,
all
ma'am.
you.
Yes, yes, ma'am.
Urine microscopy is very important. What else?
Yes, ma'am.
Other than what is important? Urine microscopy.
Yes, when there is a persistent microscopic hematuria, there could be a nephrotic component associated with this nephrotic.
Like
thing.
cast.
Yes, ma'am.
Usually in
Yes,
the
in MCNS, usually hyaline cast will be there, ma'am.
yes,
Yes.
here RBC.
Here, other things, there will be RBCs and granular casts and RBC casts may be seen. Yes.
Dr. Arun, what would you think if this child had hypertension? Would you straight away think of causes other than minimal change, or do you think in a child with this particular presentation, hypertension is possible?
Since the child is on chronic AF or on steroids, I first think of it's a complication of steroid toxicity.
All right. Any other causes of hypertension in this child?
Since the child is not having, the child is having associated hematuria, for the in evaluation, if we detect C3 low C3 level, we can consider nephritic picture also.
So, other thing is any child with a relapse, there can be fluid and water retention and sodium retention, and that itself can sometimes develop. They can have hypertension. So not all children of hypertension, you take it as an atypical feature, but if there is persistent hypertension, even after appropriate management, you would think of something else other than your minimal change, or you would also think of a secondary nephrotic syndrome. Okay. After drug toxicities and after ruling out, after adequately controlling for the fluid and salt restriction. All right.
Yes, ma'am.
Okay.
I request PGs to that's on your video, because our judges are watching and you have to that's on your videos, please.
So in the investigations, so we were thinking of conditions with low C. Madam was repeatedly asking about low complement levels. So why do you think? So if there is a low complement level, what would be your diagnostic considerations?
We can divide the normal complement levels into. Hello.
Can you?
Ma'am, is it audible?
Yes, you're audible.
If the complement level is low, we can consider. We can divide the features into. We can classify the conditions into two: systemic diseases or renal disease. In systemic disease, we can consider lupus nephritis and shunt nephritis and renal abscess. And in renal conditions, we can consider post-infectious glomerulonephritis, glomeruloproliferative glomerulonephritis.
So you can have infection-related causes, which can also lower your C3, or you can have autoimmune diseases, which can present with a lower complement.
Yes.
All right. So coming to other investigations, so if you do an ultrasound in a child with presentation with proteinuria, what are your considerations? What will you look for in the ultrasound?
Presence of fluid collections.
Specifically in an ultrasound, what will you want to look, Naveen? I mean, Arun.
You have is presenting to you with proteinuria. You don't know whether the child is nephrotic. You don't know you don't know anything. You just know that the child is probably having urinary leukoprotein. So what will you look for in the ultrasound?
Renal liquid and renal vein, whether any thrombosis.
So look at the size of the kidneys.
Yes.
This child could have chronic kidney disease with proteinuria, so you would never know.
Yes,
you can look at the size of the kidneys, you can look at the echo texture of the kidneys. And in case this child has significant hematuria or has hypertension or there is any acute kidney injury, you can also think of a renal vein thrombosis, wherein you will suspect and do a Doppler.
Nice.
in these children.
What are the common complications you anticipate in a nephrotic syndrome? Common complications. See, one case presented one complications. What are the other complications that can happen to a child with nephrotic syndrome?
The child may have subacute bacterial peritonitis, ma'am, and there may be a chance for cellulitis, pneumonia, tuberculosis, bones and joint infection, sepsis, and even meningitis, ma'am.
Any other than the infective complications, can anything else happen to a child with nephrotic syndrome?
If the child has dehydration, we may think of thrombosis, thromboembolic lesions.
Thrombosis.
Yes, ma'am.
Dr. Arun, your audio is not good.
Hello, sir.
Audio is not good. Okay.
So,
Please proceed.
so you will think these are the common complications. So when you think, okay, this child requires a second drug, something other than steroid may be required, under what conditions will, as a postgraduate, you will think, okay, I need to give something more?
In this case, if we started the child with steroid of 2 milligram per kg per day. Then we, after the remission, we switched over the drug to 1.5 mg per kg per day. And in case it's a case of frequent relapsing steroid-dependent nephrotic syndrome. So after the alternate day regimen, we can taper the drug and maintain the drug on very minimal dose to make the child sustain remission, ma'am. If the tampering dose, we need to fix the dose between 0.5 to 0.75 milligram per kg on alternate days, ma'am. If the remission, if the required remission dose is more than 0.5 mg per, or if the child developed steroid toxicity, we may consider second-line drugs like immunomodulators, like levamisole, cyclophosphamide, calcium inhibitors, mycophenolate, mofetil, like that.
Pulling you back to complications, why do you think a child with nephrotic syndrome has an increased risk of infections? Dr. Naveen.
Yes, ma'am. Children with nephrotic syndrome are at increased risk of complications because there is huge loss of globulins in the urine, ma'am, associated with that loss of proteins. So that makes them susceptible for more infections, ma'am. And
any other cause?
And
so most of these children also lose complement.
Yes, complements and properties is also lost in the urine. Yes,
which are responsible for the alternate pathway. So
yes, ma'am. Yes,
so these children are more likely to get infections with what type of organisms?
Capsulated organisms like pneumococcus and meningococcus.
Why do you think C3 and C5 are important for these encapsulated organisms? What is their function?
Phagocytosis. They involve in phagocytosis of these capsulated organisms, ma'am. So when these complements are lost, these children are more prone for capsulated organism infections.
Yes. So what are those organisms?
Strep pneumonia, pneumococcus, meningococcus.
Okay, while we are in infections, now that we have something to prevent, what do you think should be the vaccination strategy for these children?
Yes, these children must be getting the vaccines, preventable vaccines to prevent the vaccine preventable diseases caused by strep pneumonia, meningococcus, and even influenza. These vaccines are being indicated in these children when they are on alternate day steroids of around 0.5 mg per kg per day. These vaccines can be given. Live vaccines should not be given while they are on full dose of steroids.
So how long will you wait if a child is on steroids? When can you give safely a live vaccine?
After 4 weeks into the remission, I can safely give a live vaccine to these children.
And what do you expect the response to a child? Say you're giving a killed vaccine or an inactivated vaccine to a child with immunosuppression, say even on a low dose steroids. What do
Yes,
you think?
ma'am.
Will the antibody production be adequate?
No, it may be subnormal also, may not meet the expected level of
But
seroconversion.
still, with the benefit of giving
Yes,
the vaccine to the child.
yes,
Okay. So you said pneumococcal vaccines.
yes, ma'am.
Hib vaccine is already given for this child.
No vaccine was given, ma'am. Pneumococcal vaccine was not given to this child.
Was the child, but according to the national immunization schedule, do you think the child would have got a H influenza vaccine?
Yes, ma'am. H influenza, the child. Yes, ma'am. The H influenza child would have got, ma'am. Pneumococcus, it would have missed out because she has been taking vaccines from the urban primary health center.
Okay. So this child probably has not got a varicella vaccine also.
Yes, ma'am. Yes, ma'am.
So what will happen if the child is exposed to a person with varicella? What will be
She might get a disseminated varicella infection when she gets exposed. So at the skepticism of exposure to varicella infection and there is signs of fever, we may have to start the child on acyclovir injections or varicella immunoglobulins, ma'am, if available.
Srinidhi, are you with us? Srinidhi?
Yes, ma'am. Yes,
Okay.
ma'am.
Now, suppose this is a long-term illness, nephrotic. Okay. So, if you want to counsel a family, a mother of a child with nephrotic syndrome, what will be your things which you need to speak?
First, we need to explain about the course of the illness, ma'am. That it could be a longer duration, and main treatment would be we have to strictly adhere to the treatment option, ma'am. That is the steroids, which has to be given correctly, and we need to explain about the diet as well as the vaccination. And we need to ask the mother to monitor for the remission and whether the child is going into relapse. And then we have to teach her about the side effects of steroids, and we have to explain the warning signs of complications that the child would develop during the course of the illness, ma'am. Main counseling is mother has to be explained about the disease course, ma'am. That 90% of the children, if it is a minimal change disease, they would respond to steroid and they would spontaneously go into remission, ma'am.
Of course, diet is very important. The mother needs to know what she needs to give, how long, because we can have salt restriction, which is going on for years together. Okay, you cannot allow that. So we need to have a clear diet plan, which is to be given to the mother. And of course, as spoken earlier, vaccination. Okay, they have to complete the vaccination and then come back. Okay?
They should be called for follow-up of height, weight, as well as for the eye examination for development of cataract. And whenever the child comes for follow-up, we need to look for the signs of steroid toxicity.
What is the rescue dose of steroids? When will you think of a rescue dose of steroid in a child like this?
When the child is on steroids for 2 weeks, or if the child had received in the last 3 to 6 months of treatment, such children will have suppression of the HPO axis, ma'am. So if the child develops an infection, we need to think about a stress dose steroid, preferably hydrocortisone, ma'am, a dose of 2 to 4 mg per kg. And then we need to taper the steroid to 0.5.
During follow-up, one question, during follow-up, what
Yes,
about vitamins? Vitamin D.
Vitamin D, the child has, we have to supplement children with nephrotic syndrome with vitamin D as well as calcium, ma'am. About 125 to 200 international units of vitamin D should be taken daily.
Why do you need to supplement vitamin D?
Um,
So what are the causes of vitamin D
Causes for vitamin.
in this child? Why do you think this child needs vitamin D?
Since the child is on a chronic steroid supplement, they get prone for osteoporosis, ma'am.
Does the disease per se confer a higher risk of vitamin D deficiency, having a nephrotic?
Yes, ma'am. Yes,
Why?
ma'am.
Disease per se.
Yes, ma'am.
Why is that?
There is enzymes that are required for vitamin D metabolism, ma'am, like alpha-1 hydroxylase, and which needs to convert to 25 hydroxy to 1,25, which plays a major role in calcium homeostasis, ma'am.
Okay, I'm giving you a clue. You might be losing something in the urine. What is that?
Albumin, ma'am.
Albumin. So you lose a lot of proteins. One of the important proteins that you lose is your vitamin D binding
protein,
which will result in vitamin D deficiency. So these children, on account of having nephrotic range proteinuria and also on account of getting chronic steroid therapy, more likely to be vitamin D deficient, and you can supplement them along with calcium.
Okay.
Okay. Any other hormone that you can lose or any other hormonal deficiency that you can get in a child with nephrotic syndrome?
Any other endocrine issues?
Thyroid, hypothyroidism, ma'am.
Why does hypothyroidism develop?
Since the thyroid binding globulin has been lost in the urine, so we need to consider hypothyroidism.
What is the terminology used for that? Hypothyroidism.
No idea.
Thyroxine is less. Thyroid binding globulin is lost. TSH is normal. So it is biochemical hypothyroidism.
Yes, ma'am.
So you have seen one emergency in this child. What is the other emergency we face in nephrotic syndrome on therapy?
Ma'am, I'm not able. What is the other complication?
Emergency is a peritonitis. You have seen that case.
Yes, ma'am.
Other critical ill child you will see in the emergency room, nephrotic syndrome. Critically ill.
Cerebral vein thrombosis, ma'am. Presenting with headache, seizures, altered sensorium.
What are the cause for this hypercoagulable stage?
Since the liver tries to make up the lost albumin by increasing the synthesis of albumin, by the side it also increases the synthesis of coagulation factors like 2, 7, 9, 10, as well as protein C and protein S.
Good, good.
So there's loss of antithrombin 3 and protein S, right?
Yes.
There's loss of
antithrombin 3.
Yeah. So there's loss of anticoagulant factors, and there's also increase in the
procoagulant factors.
State. So you have a overall procoagulant state, so that more likely. So other than this thing, what are the other risk factors for developing a thromboembolism?
Dehydration. If the child presents with vomiting, diarrhea, it can go for intravascular depletion and the child may develop thrombosis, ma'am. And if we do not assess the intravascular status properly, and if we go for diuretic therapy, that can also further worsen the intravascular volume depletion, and the child can iatrogenically go for thromboembolic manifestations, ma'am.
What are the other sites where you can find thromboembolism? You said about
renal vein thrombosis, ma'am.
Yes.
Cerebral vein thrombosis, pulmonary embolism.
Then very simple deep vein thrombosis in the lower limbs.
Deep vein thrombosis, yes, ma'am.
Okay, now that we have talked about diuretic, this question is to Naveen. What's the indications to use a diuretic in a child with nephrotic? When will you think, okay, I need to use a diuretic for this child? Naveen?
Yes, ma'am.
Yeah.
Yeah, yes, ma'am. And when there is so much of Anasarca and the urine output is so low, and when we are sure that intravascular volume is adequate, we may try a diuretic challenge with IV furosemide 1 to 2 milligrams per kg per day.
Okay, anything else? Anything else you can try? Suppose giving furosemide is like a double-edged weapon. Anything else you can try along with furosemide?
Yes, ma'am. Yes, ma'am. When there is a profound hypoalbuminemia, I'll use 20% or 5% albumin infusion along with furosemide and try to improve diuresis.
Okay. Any other diuretic we can think of? Furosemide is the first line. Anything else can you think of?
Spironolactone can be used, ma'am, in cases. Other than furosemide, the same group diuretic, thiazodiuretics can also be used, ma'am. Same loop diuretics, bumetanide and torsemide can also be used.
What is the preferred group of diuretics in these patients?
In this patient, I prefer loop diuretics. First line, furosemide, I'll be preferring a diuretic agent of choice.
And you will go on to other classes of diuretics only if you think that the edema is refractory to your
Yes,
primary
ma'am.
line of treatment. And then
Yes,
you add on other diuretics. Sometimes you can
Yes.
add spironolactone to counteract the electrolyte imbalances, especially
Yes, ma'am. Potassium loss. Yes.
Any other benefit of adding spironolactone to these children along with loop diuretics for edema control?
Can prevent hypokalemia and compensate the potassium.
Your voice is not clear. Can you speak a bit louder?
Arun, can you talk a little louder?
Ma'am, when using the higher dose of furosemide, the child will use potassium. To compensate the potassium, we can use spironolactone.
Let me rephrase the question. So what are the mechanisms of edema that why does edema occur in a child with nephrotic syndrome? So there are a few theories for that. Can somebody?
There are two theories, ma'am. One is underfill theory and other one is overfill theory, ma'am.
Yes.
In underfill theory,
Arun, your voice is not clear, Arun.
hello?
Yeah.
Sir, is it audible, sir?
Yeah, please try.
So there are two theories, sir. One is underfill theory and another is overfill theory. In underfill theory, there is sir, is it audible, sir?
Is the break? Yeah, Naveen, you can proceed otherwise. Yeah.
Naveen, you please answer that question. Arun is not audible. Naveen,
Yes, ma'am. Yes, ma'am.
what's the mechanisms of edema?
Yes, ma'am. Mechanism of edema in nephrotic syndrome maybe because of two theories, ma'am. One is an underfill theory and the other one is an overfill theory. So underfill theory is due to the loss of excessive proteins in urine. There will be a lower colloidosmotic pressure in the blood vessels and hydrostatic pressure, and there will be higher in the third spacing. So the water tends to move away from the lower osmotic pressure. So this is the underfill theory. In overfill theory, because of the loss of proteins, there will be because of the loss of proteins and intravascular volume depletion due to this third spacing, there will be sodium retention by the kidneys, ma'am. So this underfill overfill theory states that due to the excessive sodium retention, so excess volume urine output is reduced and volume is being there is a retention of volume, and this over expansion leads to edema in nephrotic syndrome. There are two kinds of theory.
Clarify your statement. One is the underfill theory, the first one.
Yes, ma'am.
So
Yes,
underfill
ma'am.
theory occurs because your albumin is deficient.
Yes, yes, ma'am. Lost. Yes, yes,
Your
ma'am.
on-cut pressure sort of comes down. So there is
Yes, ma'am.
of fluid from intravascular
Vessel into the third space. Yes, ma'am.
So the child is depleted intravascularly.
Yes, ma'am. Yes, ma'am.
So what happens when a child has intravascular depletion? You have
Hemoconcentration, ma'am. Hemoconcentration, vascular stasis.
Low intravascular volume. So it counters a defense mechanism by activating the renin-angiotensin axis. So there is sodium and water retention. So
Yes,
the underfill theory, because of the low intravascular volume, you have a reactivation of the renin-angiotensin system, resulting in aldosterone action to retain salt and water. So you develop edema. In your overfill theory,
yes,
it is rather thought that the kidney is intrinsically problematic. So where the kidney starts retaining salt and water.
What? Yes.
It's predominantly thought to be the ENaC channels in the distal tubule. So the kidney is faulty in a child with nephrotic syndrome. So it starts accumulating fluid and salt.
Water, salt. Yes.
Yeah, so there is suppression of the renin-angiotensin aldosterone axis here.
Yes.
And then the child develops edema because of
edema, excessive fluid. Yes.
So no specific, there is, both the theories can be true in a given child at different clinical situations. Okay, and it might help you to understand. So depending on the intravascular status of the child, if you can assess clinically, I think you can also manage the child's edema better.
Yes, ma'am.
So especially in a condition with renin-angiotensin system which is reactivated, which is very high, like in your underfill theory because of the volume contraction, your spironolactone helps better.
Yes.
And in a child with overfill theory where it's primarily fluid and salt retention, loop
diuretics will help. Yes.
Okay, so that was the context of the question.
Yes.
All right. So when will you specifically? So what is the benefit of giving albumin to a child with edema? So why do you have tried diuretics? It
Yes, ma'am.
think of giving albumin along with the diuretic. So what is the benefit of that?
Most of the drugs in this case being peritonitis, antibiotics and other drugs, all of them are albumin bound. When there is a very low albumin in serum, any effect of the drug is being hindered by the hypoalbuminemia. So supplementing with albumin infusion will increase diuresis, shift of the fluid into the intravascular volume, and also assist us in treating the infections associated with this.
Yeah. So giving albumin actually increases the efficacy of your diuretics. So would you prefer to give oral diuretics or would you prefer to give IV diuretics in this child?
In this child, as the overload is huge, I'll go with the IV diuretics along with the albumin infusion.
You think oral diuretics do not help this child? Why?
It can help, ma'am. There is no contraindication for oral diuretics in this child, but given the situation, as the child is hospitalized, I'll go with the IV one.
So this child having a relapse, there's also going to be gut edema.
Yes, ma'am.
So absorption of the diuretics per se can be decreased.
Yes.
Also, the child is hypoalbuminic. So if you give an IV diuretic along with albumin infusion, the furosemide is going to tag along with the albumin and reach the kidneys properly. Whereas in oral diuretic, the bioavailability might be very little compared to an IV, and also because of the gut edema, the absorption will be very little.
So how will you use IV albumin, Naveen, and how do you monitor a child when during albumin infusion? If you're a postgraduate in the ICU,
Yes,
so you have decided to give albumin, how much will you order? And then what will be your management? I mean, what will you monitor for that during the period of albumin infusion? What
yes,
are the
ma'am.
problems?
I'll be giving 20% albumin of 0.5 to 1 gram per kg. I'll give it as a slow infusion of over 4 hours, ma'am. And while monitoring, I'll be looking for any signs of fluid overload and pulmonary congestion in the form of breathing difficulty, tachypnea, and desaturation, like that, and rails and crepes over the chest, and an enlarged liver after starting albumin.
Madam Chairman and Dr. Suganya, any more points?
Albumin.
Child, I think Dr. Srinidhi, right?
Yeah, Srinidhi.
Yeah.
Yes, ma'am.
So I mentioned that the child, one of the emergencies that the child can present is with seizures.
Yes, ma'am.
What are the causes of seizures in a child with nephrotic syndrome?
Per se cortical vein thrombosis, ma'am. If the child presents with nephritic picture, they can go for hypertensive encephalopathy resulting in seizures, ma'am.
Any
Meningitis
metabolic cause of
complication.
seizure?
The child may present with meningitis, ma'am. Or the child may present with hyponatremia due to dilutional volume overload leading to dilutional hyponatremia, ma'am.
Where else can you develop hyponatremia, especially in this child? Just now we were discussing many treatment strategies.
Diuretic.
Yes.
Overwhelming use of diuretics, ma'am.
Any of the electrolyte abnormality can
Hypocalcemia, ma'am.
What are the other complications that we're speaking? We discussed infections, we discussed thromboembolism, we discussed seizures, hypertension. So any other complications?
Cellulitis.
Those are infectious.
Pneumonia. Oh, infectious.
Any renal insufficiency?
Renal failure, ma'am. Acute renal failure. In nephrotic children, due to intravascular depletion, they can go for acute tubular necrosis, ma'am. Or due to use of any drugs, it may lead to interstitial nephritis. As well, per se, bilateral renal vein thrombosis can lead to renal insufficiency, leading to acute renal failure.
What drugs can cause renal failure? What are the drugs that can cause renal failure in this child?
Calcineurin inhibitors, ma'am. Cyclosporin, tacrolimus. Ma'am?
So this child has never received calcineurin inhibitors. Any other drugs that you would think of? Can diuretics cause AKI?
Yes, ma'am.
Yes. This child has infections, so you would be treating the child with antibiotics.
Antibiotics, yes.
Yes.
Vancomycin aminoglycosides. So that may lead to renal failure.
All right. So coming to this child with spontaneous bacterial peritonitis. So in your diagnosis, how will you confirm a diagnosis of SBP? The test.
You'll do ascitic fluid, peritoneal fluid tap, ma'am, and you have to look for neutrophilic leukocytosis of counts more than 250 cells.
Okay.
You can confirm diagnosis spontaneous bacterial peritonitis.
Anything else? The cell count?
There can be yield of growth in the culture, ma'am.
So what if the cell count is less than 250? Can you rule out peritonitis, or still would you like to consider peritonitis?
Still, we used to consider spontaneous bacterial peritonitis.
How would you do that? How would you confirm that? Something to do with the cell count, the differential count.
Neutrophilic predominance.
So how much is neutrophilic predominant? So even if your cell count is less than 250, if you have more than 50% polymorphs, I'd like to think that the child has got a bacterial cause for.
But
if you find lymphocytic predominance, would you like to entertain any other diagnosis in this child in the ascitic fluid?
Fungal peritonitis, ma'am.
Lymphocytic predominance, you would think of fungal. Any other
Tuberculosis.
etiology? Yes. Yes.
Tuberculosis, ma'am.
You're also at risk of chronic infections. So you can also develop peritonitis, and you would suspect it if there is a lymphocytic predominance. Okay.
Yes, ma'am.
What is the treatment for these children with spontaneous bacterial peritonitis? So you have confirmed it by doing an ascitic fluid cell count, a differential culture.
Yes, ma'am.
So what are the common organisms that can cause spontaneous bacterial peritonitis?
The common organisms are Streptococcus pneumoniae, ma'am, group, and E. coli and Streptococcus, ma'am, group A Streptococcus. So the line of antibiotic treatment would be first line ampicillin or third generation cephalosporin, like ceftriaxone with combination of aminoglycosides, which is given for a period of 7 to 10 days, ma'am.
So how will you monitor this child for treatment adequacy, whether the child has improved or not? So what are the
We would look
and symptoms that you would look for?
Improvement in the general well-being, ma'am. Improvement of the symptoms like abdominal pain, erythema, guarding rigidity, and bubble sounds.
So after the initial antibiotic empirical therapy,
okay,
if you find good clinical improvement, you might not want to repeat the paracentesis. But if you don't find improvement,
you need to repeat.
Okay.
What is the role of, one question, what is the role of anti-tuberculosis treatment in the child with nephrotic skin? Other drugs during therapy you have to give, what is the role?
If the child is having MAN2 positive, we can go for INH prophylaxis, ma'am, without proving active TB. Otherwise, you need to start ATT. Yes,
but we have to counsel the parents regarding this therapy, other therapies.
Yes, ma'am.
So when would you consider a renal biopsy in this child? So we did not discuss about renal biopsy.
The similar picture has been presented in age group less than 1 year or more than 10 years of age. Or if the child has overlapping nephritic picture like persistent hematuria, microscopic hematuria or gross, with low complement levels, with the systemic hypertension not resolved by medical management, and if the child has any systemic illness like fever, rash, arthralgia, we consider renal biopsy.
Would also consider renal biopsy when there is persistent renal dysfunction and you don't think it's just because of dehydration.
Yes, ma'am.
And drugs.
3 more minutes.
Okay. So when will you consider referring this child? So you have managed this child very well.
Yes, ma'am.
But would you like to refer this child to a specialist at some point? And when
the age of the child is less than 1 year old, if there is a significant family history of similar illness, if the child has persistent hematuria, microscopic gross with systemic hypertension, with underlying systemic illness, secondary causes of nephrotic. And then if the child is steroid resistant, and if the child is steroid sensitive and frequently relapsing nephrotic. And if the child has complications, we can refer.
So what would you tell about the prognosis to them? Now, the mother is very worried. So she's had almost 6 episodes in a year.
Yes,
So mother asks you about the long-term prognosis for this child. So what would you explain to the mother?
Since the age of the child is 3 years, most probably the minimal change disease usually resolves around 5 years of age. And 90% of the children respond well to steroids if the treatment is adhered correctly, both the dosage as well as the duration. And we have to advise mother for general hygiene to prevent infections with adequate vaccination. And the diet counseling has to be given.
Do you think this child will land up with kidney failure in the future?
No, ma'am.
Why so?
It is a transient condition.
So it's children
And it's
with nephrotic syndrome. So that is the main
steroid sensitive. Yes.
Steroid sensitiveness means a benign course. Although the child might have relapsing disease, might have frequently relapsing, steroid sensitivity and response to steroids is the best prognostic marker for this child, and most of these children have a very good long-term prognosis. Usually, long-term prognosis is bad in children with steroid-resistant nephrotic syndrome and who do not respond to medications. So if you're going to be persistently proteinuric in spite of treatment and have steroid-resistant nephrotic syndrome, so your prognosis is going to be bad, renal prognosis.
Yes,
message also should be, you should tell them, see, because it's a long drawn illnesses, there is a chance they may end up with a native treatment. We have seen these children also. They will come back desperately sick, taken off all these drugs. So you must tell them that this is the way it will happen. You have to give a positive reinforcement and talk to them as and when required, and tell them not to go for any other alternative medicine which can land up in more disasters. They have heavy metals, so child can come back with a renal failure because of the drug that was given outside also. So we need to be very sure that we need to counsel this family not to, get trapped by the other things that are being mentioned in the outside world, right?
Yes, ma'am.
Worthwhile mentioning at the first episode itself, almost 75 to 80% of children will at least have one another episode. They would not stop with one episode of nephrotic syndrome. So you can counsel the parents upfront that they should expect recurrence of these episodes.
Relapses.
Yeah. And what's the percentage of frequent relapser or steroid dependence? Say you have 100 children with nephrotic syndrome, and how many of them do you think will have steroid dependence or frequent relapsing nature of the disease?
80 to 90.
80 to 90, that's quite a high value.
18 to 20 are sensitive, okay? So the remaining only are going to be having problems, okay?
Breakup,
Yes.
as madam said, almost 80 to 90% will be, almost 90% will be steroid sensitive. Remaining 10% can be
10%.
steroid resistant at the first episode itself. And in the steroid sensitive group, at least 75% of them will have at least one more relapse.
Yes, ma'am.
And of these children, half of them will go on to develop frequently relapsing or a steroid dependent course. Rest of them can have infrequently relapsing course. All right, these might be asked in your exams.
Yes, ma'am.
Thank you, madam. Thank you.
One point, sir. 1 point. Examination of the skin, hair, and external genitalia is very important. External genitalia for congenital nephrotic syndrome, skin infection as well as rash. General examination, we have to mention about this information. Thank you very much for the opportunity.
Okay, madam. I will request our judges to comment, please. If they want to add any points, Dr. Srinivasan sir and others, Dr. Janani madam, Dr. Balasankar sir, Dr. PRC sir, Dr. Elizabeth madam. Sir, unmute, sir. Sir, unmute.
Very extensive coverage of the whole problem. And if you want me to tell, of course, candidate faced it very well. So it's a very good beginning. So, and all the questions are the common questions, and it went till the advanced management of case which is not responding or frequently relapsing. So, a lot of information have been given to the watching postgraduates. Thank you so much. It was a good job done. Congratulations, all of you, and wish you once again Happy New Year.
Thank you, sir.
So, anybody, any comments, please? Yeah. I think it's on behalf of IAPTNSC, I thank Dr. Umadevi Madam and as a chairperson and excellent feedback also. And I thank Dr. Jyoti, is Professor of Pediatrics, PhD Medical College, and their team, particularly Naveen Kumar has presented very nicely and interacted very well and answered all questions almost. I thank Dr. Naveen Kumar and the PhD team and under the guidance of Dr. Jyoti. And I thank Suganya, and I think this is excellent specialty oriented. That's a discussion and from Meta Medical Center. I thank Dr. Suganya, and I thank all the judges.